In this unit, we're going to focus on drugs, their use, and the consequences people face as a result of using them. When we finish this lesson, I hope you're going to have a better understanding about the drug use situation, including the types of commonly used drugs, how they're used, and the effects of each of those people using drugs, each of the drugs themselves. The four main drugs that I'm going to talk about are heroin, amphetamine, ecstasy, and cannabis. And for each of these drugs, I'm going to talk about what it is, how it's used, its effects, including both immediate and long-term effects. Some of the more commonly used drugs are marijuana, alcohol, nicotine. Those would be the top three. But we also have cocaine and heroin, and more recently, opioids and methamphetamines. Those are the more commonly used drugs. So I want you to think about, before coming in here, what did you think about drug users? Some of the myths that are out there that drug users are bad people, or they're weak-willed, or they have moral issues. They're liars, they're manipulators, they're cheaters. They're just general all-around bad people. They can't hold a job. They're strung out. These are the type of people that are homeless. We hear this a lot. And how are drugs used? Do people smoke them? Do they shoot them up? Do they snort them in their nose intranasally? What about skin popping? What about eating them? There's so many different routes of administration for substances. Do they inhale them? What are some of the common patterns of use that you have thought about? Do people use them every day? Do people use them just on weekends? Are they using them at the end of the day? Are they using them all day long? Are they using them on special occasions, like at parties or holidays? What about some of the risks that are associated with use? What do we know about that? People can be arrested. They can get into car accidents. They can have hangovers. They can have blackouts. They can get injured. They can fall and hurt themselves. But also, they could possibly ruin a relationship with someone. They can have their kids taken from them. These are some common risks that are associated with substance use. Maybe we need to start thinking about some of the local names for the drugs. Instead of methamphetamines, most people call it ice or speed. Instead of marijuana or cannabis, people are calling it weed or grass, or they might refer to it by the strain name like OG Kush or bubblegum or Skittles or green. In some other different types of drugs, ketamine or whatever, ketamine sometimes is called Special K. So we have to also know the lingo when we're dealing with people in this field. It's important for us to know some common routes of administration, like injection, snorting, mixing with another drug. Some people are putting fentanyl in their drugs. Some people are lacing marijuana with cocaine or heroin or also with fentanyl. And then we need to know the popularity of those major four drugs among different risk groups, like with youth or college students or sex workers, urban professionals. And we need to know the current popularity and popularity over time. Is it increasing, decreasing, stabilizing? So it's important for us to know what's going on in our local community in order to successfully treat those in our community. So as you can see here, alcohol is the #1 consumed substance in the United States, followed by cigarettes, then marijuana, then pain relievers, also tranquilizers, and cocaine and stimulants are right there around the same amount. And then just underneath that is methamphetamines and ecstasy. And they're making ecstasy with methamphetamines, but also they make it with cocaine as well. And then inhalants and sedatives, and then heroin, crack, LSD, and PCP is the last one. Although this session does focus on the drug use situation, I want to make sure that you all understand the common definition of the drugs that we are going to talk about. I want you to think about how you define drugs. I have a lot of people saying marijuana is not a drug. Okay, so how do you define a drug? Is it something that is psychologically altering? Is it something that has negative effects? Is it mood altering? What is your definition of a drug? A psychoactive drug is any chemical substance which, when it's taken into the body, alters its function physically and psychologically. So think about, have you ever used any drugs? And if you haven't ever used any drugs, do you drink coffee or caffeine? What about smoking cigarettes or drinking alcohol? There's a variety of different substances that maybe you don't think of as a psychoactive drug. And we have to think about why people take drugs. Is it for fun? Is it to forget? Is it to function normally or function at a higher level? Or maybe function at a lower level. If you have high anxiety, you want to bring your functioning level down. While there's a lot of different reasons for initiation and continued use of both illicit and licit drugs, the key motivators pivot around 3 main factors, and these motivators are not mutually exclusive. And they're going to include fun, or for forgetting, or to improve functioning. And a person may take drugs for any or all of these reasons, and they may not even be aware that these are the underlying drivers of their drug use. So I want you to think about some examples for each of these categories. In the fun category, we're using it to hang out with friends at a party, or we're using it to relax on a vacation, or we're using it when we go out to the restaurant so that we have a better time. Or maybe they're using it to forget. Maybe they just got into an argument with their spouse and they want to just forget that it even happened. Or maybe they got fired from their job and they just cannot deal with the emotional stress and pain of that. And so they go and use. Or maybe someone just passed away that was close to them and they just don't want to deal with those emotions. And then to function. Like I said, maybe they have high anxiety and so they want to bring themselves down back to a normal level. Or maybe they're really depressed and they want to pick themselves back up. Or maybe they're tired and they want to have more energy. So these are some of the examples. People take caffeine pills or amphetamines to stay awake, or we use aspirin or even heroin to stop the pain. Psychoactive drugs alter several things. It's going to alter your mood. So when a psychoactive drug enters the user's body, it changes their mood. So for example, someone may become happier. They might feel that they've just become a different person. It affects their cognition or their thoughts. Users perceive things differently when they're taking drugs, and this is going to relate to the way that they process information and apply that knowledge. It's going to affect their memory, their organization and planning skills, their ability to think abstractly, and also it's going to affect their decision making. And all of this influences their thinking. So, for example, when they're not intoxicated or not under the influence of a drug, they might have a different perception about risk taking and understand that sharing needles is a dangerous thing and it's going to put them at risk. But when they're intoxicated, they might perceive things differently and perceive needle sharing as low risk or an acceptable risk. We have to remember that drug users might use many drugs. So if they're intoxicated with alcohol and decide to use heroin, needle sharing might not seem so risky at that point. And we also need to remember that drug users who use heroin don't always wait until they're withdrawing to use heroin again. Some use again while they're still intoxicated. And then it's going to affect their behavior. The way people act under the effects of drugs is going to be noticeably different. Their physical appearance may be altered, and they may be unsteady on their feet, or they may have slurred speech, or things like that. And there can also be other differences in behavior, like they become violent or they act out of character. There are various drug classifications, and these are somewhat arbitrary groupings, but they provide a useful reference tool for approximating the relative drug effects or the possible risks and potential withdrawal features. The classifications in this slide shows how these drugs affect the brain. So classifications are intended as a general guide only, as variations in the effects and the intensity may occur for drugs within the same class. So, for example, although ecstasy provides similar stimulant effects to amphetamines, the effects are generally not as intense. And in higher doses, ecstasy may have additional hallucinogenic effects for people. And opioids have been classified as depressants because of their primary effect on the brain. But for the purposes of this training course, cannabis has been placed in the central nervous system depressant category because its primary effects as a central nervous depressant, and in the hallucinogens category because at high doses, cannabis can produce hallucinogenic effects. Now, this model presents a systems perspective on the drug use experience. It combines Zenberg's interactive model of drug-related harm with the principles of social learning theory. The interactive model suggests that the interaction between the drug and the environment and the individual is crucial to the overall experience from the drug use, and each factor can't be considered alone. And then within each domain, the drug, the individual, and the environment, the relative importance of each factor, like their emotions, peer pressure, route of administration, and things like that. So the relative importance of those things on influencing somebody's drug use experience is going to vary from person to person and from situation to situation. And then some of these factors may overlap from one domain into another, like drug availability may be an environmental factor, a drug factor, or both. But the most important point is that each domain and interactions between the domains need to be considered when we examine the drug use experience. Now, this slide represents the relative proportions of people who use psychoactive drugs based on their type of use. And the vast majority of drug users are people who use drugs on an experimental basis. They use them infrequently based on opportunity and availability, and most of them cease their drug use on their own free will, and they don't go on to that more intensive pattern of substance use. And then as the drug becomes more intense and regular, it takes more precedence in an individual's life, and then tolerance emerges along with the other features or consequences of that intensive use. And then ultimately drug addiction emerges. And the proportion of drug users who ultimately become addicted to drugs is influenced by many things. We have to just remember that not all people who use a drug will ultimately become addicted. If we were to sit in the room and come up with a list of all the risks and problems that are associated with substance use, we might be able to come up with something like this Venn diagram. Thorley conceptually described problems associated with drug use as belonging to three domains: intoxication, regular use, and addiction. The diagram shows that his domains are not mutually exclusive and that it is possible to have problems in one, two, or all three domains. The problem listed in each of the domains in this diagram are not exhaustive, they're just some suggestions here. But if we look under intoxication, a single episode of intoxication can cause a variety of problems. Accidents often occur when somebody's intoxicated or drunk. Hangover usually follows the intoxication. Overdose can result from intoxication. Risk perception is altered when somebody's intoxicated, and they're more likely to share injecting equipment or have unprotected sex, things like that. And then if we look at regular use, heavy regular use can cause a variety of problems. Long-term excessive alcohol use leads to liver damage. Heavy drug use is expensive, so people lose their finances, their fortunes. Regular heavy use can cause personality changes like depression or mood shifts, and that can lead to relationship problems. And then repeated heavy heroin use can cause frequent non-fatal overdoses that can cause brain injury and poor memory or memory loss. And then addiction, we're going to cover the features of addiction in a later lecture, but physical addiction is characterized by the presence of withdrawal symptoms, and psychological addiction is characterized by the presence of cravings and use despite its harm. Have you ever seen heroin before? So pictured is heroin. It's the first illicit drug that we're going to discuss. I want you to think about all of the things that you know about heroin. Heroin is a derivative of the opium poppy plant, and it belongs in the class of drugs known as opiates. Opiates are derived from the white sap of the flowering poppy plant, which contains morphine and codeine, both of which are very effective painkillers and are used in many prescription medications. Pure heroin is a white powder with a very bitter taste. Its less refined forms of heroin are known as black tar. It's a gooey black or brownish substance. And then the chemical name is diacetylmorphine. And heroin fits into a larger family of opioids, some that are natural, such as opium, some that are synthesized from natural opioids, such as heroin, and some that are completely synthetic, such as methadone. Pure opioid agonists, of 20 naturally occurring alkaloids, only morphine and codeine have analgesic or pain-killing properties. And then when we look at semi-synthetic opioid agonists, like heroin, it's a chemical derivative of morphine. And then when we look at synthetic opioid agonists, like methadone or that is a hard word to say, dextropropoxyphene. These share a common structure that enables interaction with the opioid receptors in the brain. And these entirely artificial drugs have been synthesized without beginning with a naturally occurring opioid. So some commonly used opioids include heroin, morphine or morphine-based medications, codeine phosphate, and codeine-based preparations like cough mixtures, methadone, oxycodone-based medications, and then the dextropropoxyphene contained in medications. And opioids act on three main families of opioid receptors. The first receptor is linked to addiction. The opioid receptors are located in the brain, the spinal cord, and periphery, including non-neuronal pathways in the gastrointestinal tract. And that results in effects such as cough and respiratory suppression, reduced GI motility, so people get nausea and vomiting, small pupils, and urinary retention from increased bladder and urethral tone. Opioid receptors are inhibitory. They inhibit the release of other neurotransmitters like serotonin or GABA and glutamate. And they also enable the release of dopamine, which contributes to the addiction potential of the opioids. So what's actually happening is the GABA and the glutamate are actually there to regulate that dopamine flow. And if it's blocking it, then the body can't naturally get rid of the dopamine or make less of it. And so we get an influx of it. And the effects exerted through the limbic system in the brain produce changes in emotions, like that euphoric high that we feel. And the variety in chemical structures of the opioid class result in important differences in their absorption and metabolism. And morphine is rapidly metabolized by the liver after oral administration, so only a small amount reaches the rest of the body and the brain. Heroin is metabolized first to what we call MAM, or monoacetylmorphine, then into morphine. And as heroin and MAM are more fat-soluble than morphine, they can cross that adult blood-brain barrier more rapidly than morphine, which results in more intense feelings of euphoria. And codeine is also converted to morphine in the liver. 8 to 10% of Caucasians and 2% of Asians lack a specific enzyme, and codeine will have no analgesic effects for them whatsoever. And heroin is used in a number of different ways. It can be injected into the vein. We call this mainlining. Smoked in a water pipe or a standard pipe. It could be snorted as powder via the nose, or used alone or mixed with another drug. So what are the immediate effects of heroin use? Once heroin is injected or smoked or snorted, the user experiences a feeling of euphoria, also referred to as a rush. At the time of the rush, the user usually feels a warm flushing of the skin, dry mouth, and a heavy feeling in the extremities. He may also experience nausea or vomiting and severe itching. The time that it takes to achieve this feeling of euphoria is going to differ depending on the way that the heroin is used. So if it's injected into a vein, euphoria is reached in 30 seconds. If it's sniffed or smoked, euphoria may be reached in 10 minutes. The effect is going to vary depending on the person. But after the rush, the user is usually going to feel drowsy for several hours. Their mental functioning is clouded, their heart rate and their breathing are slow, and once the effects of the drugs wear off, the euphoria is going to subside. Some of the immediate effects of heroin use are going to include a slower breathing and pulse, lower blood pressure, contraction of the pupils. They're going to feel itchy and have flushed skin and a dry mouth, dry skin, dry eyes. And the small pupils are really due to increasing parasympathetic nerve tone in the pupil. And the urinary retention is due to increased urethral and bladder tone. So what are the consequences of heroin use? Continued use produces tolerance. Hence the increased doses that must be used to achieve the initial euphoria. and that's going to put the user at greater risk of overdose. Tolerance to opioids develops rapidly, commencing with first dose and then involves downregulation, which is a reduced number of receptors, and desensitization, which is a diminished response to receptor action. And then at higher doses, sedation can be extreme, and an overdose can result, like unconsciousness, coma, and death from respiratory failure. So when not taking the drug, the users often experience symptoms of withdrawal, such as restlessness, muscle and bone pain, insomnia, diarrhea, vomiting, and cold flashes and goosebumps. Heroin is highly addictive, and it's a drug that alters brain functioning. Problems with health and social and financial, vocational, family, or legal areas can occur. And heroin use also puts users at risk of HIV transmission through sharing of injecting equipment and impairment of judgment, which is increasing the likelihood that they're going to engage in high-risk behaviors. So there's little evidence of long-term direct toxic effects of the central nervous system from using opioids. However, there are a few complications that can result from that long-term chronic opioid use, and one of those is constipation. And this is characterized by bloating, vague abdominal discomfort. Physical examinations and investigations are negative, though patients may have dilated bowel with no obstructions. Then we have depression. Changing drug use behaviors requires significant social change, and it's not unusual for patients to experience depression or sadness in the face of significant change and to require time to adjust to a different lifestyle. It also has brain damage. There's a risk from repeated non-fatal overdoses of significant impairment in mental functioning. Organizational skills, planning skills, and memory can all be affected. And then the endocrine system is affected. Heroin use affects the endocrine system by changing the sex hormones in women. This results in menstrual changes and reduced libido, and it can also lead to reduced testosterone in men and a reduced libido in men. Now we're going to discuss amphetamine-type stimulants. Amphetamine-type stimulants are a family of substances that have a common core composition and are differentiated by the composition and location of sidearms that hang off the central molecule. They have varied effects that really just depend on the location and the composition of the substituents. So today we're going to talk about two of those, namely methamphetamine and MDMA, or ecstasy. So what do we know about methamphetamines? There are many different forms of methamphetamines. The salt variety is typically a powder that dissolves easily and is often injected or snorted. Crystalline or ice or tablets, which have been compressed, are the same composition but of higher purity. The freebase form can be sold as a yellow or brown liquid. Methamphetamines come in many different forms, and they can be smoked, snorted, orally ingested, or injected. And ice, a form of methamphetamine that can be smoked, people typically smoke it in a pipe or on a foil, and it produces effects that can continue for up to 12 hours or more. It's a large, usually clear crystal of high purity. It's usually smoked in a glass pipe. The smoke is odorless, and it leaves a residue that can be re-smoked. And like I said, it produces that effect for 12 hours or more. And methamphetamines increase the levels of dopamine in the brain. It does this by causing the release of dopamine from the nerve cells, as well as by blocking the reuptake of dopamine back into the nerve cells. It also inhibits the enzyme that breaks down dopamine if it stays outside of the nerve cells for too long. And besides increasing dopamine levels, methamphetamines do increase levels of serotonin and noradrenaline. And dopamine and serotonin cause the sensation of pleasure that the drug users are seeking. The unintended side effects increase of noradrenaline are often problematic for that drug user. And users like those central nervous system effects, and they dislike the peripheral nervous system effects, like the release of adrenaline, which raises the heart rate. So some of these are the acute effects of the immediate effects of methamphetamine use. Immediately after smoking the drug or injecting it intravenously, the users are going to experience an intense euphoric rush or a flash that only lasts a few minutes. And it's described as extremely pleasurable. Snorting and oral ingestion produces a euphoric high, but not an intense rush. And snorting produces effects within 3 to 5 minutes, and oral ingestion produces its effects within 15 to 20 minutes. But they get that desired feeling of well-being or euphoria, that increased energy, the wakefulness or alertness, a reduction in their hunger, an increase in their clarity of thinking, their competence, their sociability, and they have feelings of sexuality and an improved mood. The physical effects of methamphetamines are similar to those of other stimulants. So when taken by mouth or snorted or smoked, the user usually experiences feelings of euphoria and heightened alertness and greater energy. Heart rate and blood pressure increase, and the sensations of hunger and fatigue are reduced. And the heart palpitations may be experienced. The mouth usually becomes dry and swallowing is difficult, which makes eating food difficult. Urination is also difficult. The user's pupils are large and the reflexes are faster, and rapid speech often happens. And methamphetamine users may feel invincible and attempt to perform tasks that they are incapable of performing. So here for your reference is a slide that lists some of the long-term effects of stimulants on the body. I know it's kind of difficult to see how small that is, but it's a lot. So if you want to pause the video just to take a look at this, I'm not going to spend a lot of time here. And with prolonged experience or exposure to methamphetamine, serious physical and psychological and health problems can develop. Addiction and mood disorders can develop, and mood disorders can lead to depression or violence. And there's a really great risk of psychosis with chronic high-dose usage. Psychosis is 11 more times likely to happen among methamphetamine users than among non-methamphetamine users. 1/3 of dependent users have symptoms. Hallucinations and delusions are common, and these usually stop after a few weeks when the users stop using the methamphetamines, but they can persist in about 10% of users, and they can have these effects for long term. The common street name for MDMA is ecstasy. So I want you to think about what you already know about MDMA. Probably not a lot for most people. MDMA is both a stimulant and a hallucinogen. And like methamphetamine, it's an amphetamine type substance. It's sold as a tablet or a capsule. It is a synthetic chemical that can be extracted from an essential oil from the sassafras tree. Its chemical name is 3,4-methylene dioxy-N-methamphetamine. And counterfeit methamphetamine is often sold as ecstasy. Ecstasy predominantly works on the brain by increasing the concentration of serotonin outside of the nerve cells. It also causes a large increase in the amount of dopamine outside of the nerve cells. And these changes in the levels of serotonin and dopamine cause increases in nervous activity. Serotonin is the main transmitter in the brain that's responsible for regulating mood, sexual activity, and sleep. And these are the desired effects that the drug user is seeking. Also, serotonin is important in memory and temperature control. And long-term use of ecstasy impairs memory, while the short-term effect in some people is overheating, which is a big problem, and some people can pass out or even die from it. The street doses of MDMA generally run from about 50 to 150 milligrams. An average single dose is generally considered to be about 100 milligrams. And MDMA is usually pressed into pills or loaded into capsules. And the primary route is oral, and the effect lasts approximately 3 to 6 hours. Less frequent is injection or smoking of the drug, though that does occur. And there is a powder form of MDMA that can also be sniffed, but that's less common. MDMA is notoriously unreliable in content. There are a number of chemically similar substances to MDMA that are commonly sold as MDMA on the street, and that actually does include methamphetamine, and some are actually pressing cocaine into it or heroin. Mild to moderate doses of MDMA produce a euphoric sense of well-being and a sense of feeling of connectedness with and empathy for other people. MDMA also causes an enhanced sense of pleasure and self-confidence and increased energy. And this love effect has become most closely associated with MDMA use. Its stimulant effect has made it a favorite on the club and the rave circuits. And in the hours after taking the drug, MDMA produces significant reductions in mental abilities. And these changes, particularly those affecting the memory, can last for up to a week and possibly longer in regular users. The fact that MDMA impairs information processing emphasizes the potential dangers of performing complex or even skilled activities, like driving a car, while under the influence of this drug. So over the course of a week following moderate use of the drug, a lot of MDMA users report feeling a range of emotions, including anxiety and restlessness, irritability, and sadness, that in some individuals can be as severe as true clinical depression. Similarly, anxiety, impulsiveness, aggression, as well as sleep disturbances or a lack of appetite and reduced interest in and having pleasure from sex have all been observed in regular MDMA users. And some of these disturbances may not be directly attributable to the MDMA, but may be related to drugs often used in combination with MDMA, like marijuana, or from adulterants found in the MDMA tablets. And all of these adverse consequences are extremely rare. Overheating, seizures, cardiac arrhythmia, stroke, liver damage, things like that. So think about the consequences of MDMA use. For some people, MDMA can be addictive. Almost 60% of people who use MDMA report withdrawal symptoms, including fatigue, loss of appetite, depressed feelings, and trouble concentrating. For pregnant women taking MDMA, the potential adverse effects of MDMA on the developing fetus are a really great concern. The use of MDMA has been linked to high-risk sexual behaviors that lead to HIV infections or other sexually transmitted diseases. And some report using MDMA as part of a multi-drug experience, like mixing other legal and illegal substances with it. And then, of course, there's damage to brain cells that's been associated with evidence of both short and long-term memory impairment and difficulties with learning. But it's still unknown whether the damage causes any long-term problems. Now we're going to discuss cannabis. THC is one of over 120 different cannabinoids present in the cannabis plant, and it's the one that is responsible for the psychoactive effects. There are a few different ways that cannabis is smoked based on international experience. I'd like to tell you just a few of the terms that are used to describe these mechanisms. So a joint, that's a cigarette that contains cannabis or cannabis plus tobacco. A pipe is a tube with a cone or a reservoir at the end, and it can have many different styles. A bong is a cone that's attached to a vessel containing water with a mouthpiece. And then there's other ways that cannabis is smoked or consumed. It can be ingested, like in different cakes or gummies, or I've even seen cotton candy. People have made steak with it, bacon, all types of food. Basically, if you can cook it, somebody's probably cooked it with cannabis. So this list outlines some of the possible effects that may occur as a result of using cannabis. However, the relative severity of these effects or their consequences may vary enormously according to individual chemistry, previous use, experiences and expectations, and just a range of environmental or other factors. So gaining an understanding of the impact and the effects and the harms for a person using psychoactive drugs rather than focusing on the drug itself is a key in gaining credibility and developing a relationship with clients who use these psychoactive drugs. Remember that adverse effects considered of clinical importance from the perspective of the counselor may have little relevance for the person using the drug. There's been countless times where I say people become paranoid and have hallucinations when they're on cannabis, and every single time I have somebody in my group that'll say, I've never seen that happen, because it may not have happened to them or to anyone that they know. So focusing on the effects of the drug for that client is going to be of very valuable importance. And this is a list of some of the immediate high-dose effects of cannabis. Pseudo-hallucinations. These are ones which a person's able to tell are not real. A true hallucination is where a person is unable to recognize the hallucination from reality. But a pseudo-hallucination is they know that it's not real. Cardiovascular and respiratory system effects include increased heart rate and low blood pressure if the person stands up too quickly. A short-lived psychotic state associated with a high dose is possible. It usually resolves within a week of abstinence, and it may be difficult to distinguish from the precipitation of psychosis in those with a predisposition to mental illness. And cannabis may precipitate or exacerbate certain mental health problems, like schizophrenia, in those with a predisposed vulnerability. But this link hasn't been studied very well yet. In many individuals, mental health problems that arise during periods of psychoactive drug use may resolve and not recur when the person has been abstinent from the drug. And clients who have experienced adverse psychological or physical effects linked with their use of psychoactive drugs could be actively discouraged from reinstating their use. Heavy users can exhibit lethargy, emotional apathy, mental slowing, memory impairment, and poor planning ability, which is sometimes referred to as the amotivational syndrome. But this condition has not been clinically proven, and some argue that the effects experienced are merely just the consequences of constant intoxication. And there are a number of long-term effects due to regular and heavier use of cannabis. Respiratory system effects include bronchitis, asthma, sore throat, chronic irritation because it exacerbates asthma. And cannabis contains more tar than cigarettes. It's actually 5 times more. So cannabis smoke can be more highly carcinogenic than tobacco smoke. And many cannabis users are also dependent tobacco users. So harmful effects are mostly associated with the route of administration. So for example, smoking it may lead to chronic bronchitis, and it can also result in cancer. Cardiovascular system effects include increases in heart rate, but decreases in the strength of contraction. And people with cardiovascular disease can experience a decrease exercise tolerance. Cognitive impairment may include depression, anxiety, rapid mood changes have been reported, and precipitation of schizophrenia in vulnerable populations. The effects can be subtle, but they do include effects on memory, attention, organization, and integration of complex information. Although the current evidence suggests that these effects are not grossly debilitating, their reversibility is unknown, though. And cannabis addiction is characterized by a variety of cognitive, physical, and behavioral symptoms, like poor ability to control their use, continued use despite evidence of problems, withdrawal syndrome like anxiety, depression, mood swings, sleep disturbance, memory problems, non-specific physical discomfort, and also high tolerance. And concerns are emerging that addiction may develop rapidly in younger people and may be more severe than previously thought. It's estimated that 2 joints per day for 3 weeks is sufficient to induce withdrawal symptoms in some people, although daily use for several years has not resulted in withdrawal symptoms in cessation in other people. So, in summary, psychoactive drugs alter physical and psychological functioning. And there are examples of depressant and stimulant and hallucinogenic effects that are used in the US. And the drug use experience is an interaction between the drug, the individual, and the environment. And all drugs have short-term and long-term consequences that are dependent upon the pharmacology, the individual psychology, and the sociological context.